The last of our Wednesday evening webinars for this academic term. And I'll say more about this when we come to close at the end. But we would very much like to have your feedback as to how you found the series, topics that you might want to have covered, and the format that you enjoyed, because unfortunately we're working a little bit in a vacuum doing all of this remotely. So this evening we've got a very interesting topic, advances in colorectal surgical oncology, something that's reasonably close to my heart, having practiced for 30 years as a consultant colorectal surgeon. And during that time, there have been enormous advances. Colorectal cancer, when I started, was very much the remit of the general surgeon, and there were relatively few specialist colorectal surgeons in Ireland. Relatively few had gone and done subspecialty training at St. Mark's or in the States. It has evolved, as have all other specialties, I suppose, into a subspecialty of its own. And even within colorectal surgery now, surgical oncology is almost a subspecialty, with proctology and inflammatory bowel disease and functional disease disorders becoming more subspecialized. So this evening we've three speakers: Peter Neary, known to all of us, Professor of Surgical Oncology and consultant colorectal surgeon in University Hospital Waterford. Peter has spent some time training with me, and I'm delighted to see his progress and his success. Ian Reynolds, who's a general and colorectal surgery SPR. I think, Ian, you're ST8 now and based at St. Michael's Hospital. And then last to speak will be Caroline Fogarty, who's the colorectal clinical nurse specialist at Beaumont Hospital. And I have to declare honestly, the most important person in the colorectal team is in fact the clinical nurse specialist, who has the closest liaison with the patients and who organizes the rest of us. If you're got any sense, you do what your colorectal nurse specialist tells you to do. So Caroline is going to talk to us about the most important person, the patient, and the patient pathway. Peter is going to update us on new techniques and where we are in terms of surgical techniques. And Ian is going to deal with the very interesting topic of big data. Population stats, telling us what is happening in the real world and not just in the ivory tower, which decides to publish its results. So with those few words, I'll ask Peter to start the proceedings, and I'll hand over to you, Peter.
Many thanks, President O'Connell, and many thanks to Professor McNamara, Mr. Warwick Kelly for the invite. Great. So I just wanted to verify if the screen is sharing okay there, please.
Perfectly, thanks.
Great. So many thanks for the invite for the talk on essentially the colorectal cancer surgery in the modern era. I wanted to focus on surgical advancement solely, and for me, the transition towards minimally invasive surgery has been massive in the last 25 years, and it's heading at a very steady rate, and it's progressing very quickly. I also wanted to touch on the increase in the invasiveness of diagnostic modalities, particularly colonoscopic management, which is now a very therapeutic modality. So this is a patient presented 1 year ago after a gunshot to their abdomen at University Hospital Waterford. I suppose I wanted to say this is a maximally invasive approach, and this saved the patient's life, and there's nothing wrong with open surgery. In fact, it will always be there, and it'll always be extremely important. So the purpose of this talk is not to undermine that in any shape or form, but patients' expectations are changing, and certainly patients feel if an operation can be done with the same outcome, with less pain and less damage to their body, they certainly are seeking that at the moment. For example, this is a 73-year-old lady. She presented with a large tumor in her anus infiltrating into her vagina. It was very painful on defecation. Thankfully, her imaging shows it was non-metastatic disease. So in an effort to cure her with chemoradiotherapy, she had a defunctional loop ileostomy performed prior to starting treatment. So essentially, we put a pore through the Mark trephind in the right iliac fossa and put a laparoscopic bowel grasper through the same peritoneal defect. As you can see, you have the cecum large intestine on the right, and you have loops of small intestine on the left. And essentially, 15 to 20 centimeters proximal to the ileocecal valve, we grab the small intestine and we pull it out through the Mark trephind site, ensuring orientation is adequate. So pain is minimal in these patients, and advancements are happening all the time in this manner, and it's getting better for the patient. This patient went home day 2 following restoration of bowel function. So the evolution of surgery, at least in my opinion, proceeds like follows. Open surgery is still a huge part of the surgical armamentarium, and then 25 to 30 years ago, laparoscopic surgery was introduced. Went on to robotic surgery, and robotic surgery is still advancing at a very fast rate. About 10 years ago, natural orifice transdental luminal surgery came into vogue, and probably due to the technology wasn't able to keep up with it and to give good enough exposure, it came out of vogue. However, TAMIS now for rectal lesions is pretty commonplace, so transanal minimally invasive surgery. And then if you look at diagnostic modalities, in particular endoscopy, so colonoscopy was a diagnostic only procedure at one place, but that's moving now to much more advances. You can unblock colonic obstruction with stents, and you can remove large precancerous lesions through endoscopic mucosal resection, and certainly the new kid on the block is endoscopic submucosal dissection. So rectal cancer excision, and I'm going to avoid talking about APR for this talk, it can be transabdominal, open laparoscopy and robotic, and transanal. More recently, transanal total mesorectal excision, and for precancerous lesions, TAMIS and colonoscopic, EMR, ESD. So this is a 39-year-old man presents with bleeding per rectum. So what do we do next? So at the time of colonoscopy, we ensure that there's no other colonic lesions. It's an anterior located lesion in the mid-rectum, and it's really important to figure out, before you do anything, is this likely to be malignant or precancerous? So you have your Pluto, your Paris classification, and essentially you're looking to see if it's homogeneous or if it's heterogeneous in its appearance. So if it's the vascularity, mosaicism, and pit pattern are same throughout, it's probably the best we're doing at the moment. It's really important to mention the ongoing study that's going on with Mr. Niall Hardy and Professor Cahill, who's trying to evaluate preoperatively with these lesions the likelihood of being malignant or not. And through the injection of indocyanine green and fluorescence through inflow and outflow characteristics, they're coming up with some good data suggesting that it can be predicted. And we're eagerly awaiting the results of the final results of this should become the mainstay of treatment. Pauline, would you mind playing the video, please? So again, this is the patient now undergoing TAMIS. So you put in your gel port, you demarcate the lesion, and essentially you can see TAMIS was once thought it can only take up 30% of the circumference. We can, thanks Pauline, move it forward a bit again, please. But you can actually take a lot more than the circumference of 30% out for these lesions. Thanks Pauline, we might move it forward to 2 minutes and 10 seconds, please. The fact that it's the same as any transabdominal operation, that if you essentially if you close it transversely, you won't narrow the lumen. So same as any stricturoplasty. So employing both techniques together, you can remove pretty extensive lesions through a TAMIS. So essentially, when the lesion is removed, and this is an anterior lesion, the patient is placed prone, you leave a large defect into the peritoneal cavity. And it's important that the closure is done transversely. We use a barbed V-lock stitch. It's very difficult to do it without a barb suture. Great. So if things can't be removed with a TAMIS, you have the option of removing rectal lesions or any colonic lesions unblocked through an endoscopic submucosal dissection. And you can see here in the top left picture, essentially what it means is that you demarcate the lesion, you inject your colloid mixed with indocyanine green underneath the lesion, and if you see in the bottom left-hand picture, your colonoscope as an introducer with a needle tip, it's 1.5 millimeters in size, and you use pulsed diathermy in a cut mode to remove the lesion and block. And in a skilled hand, this can be done. To prevent for colonic preserving surgery and does not need to be closed. And then we've transanal total mesorectal excision. So essentially, what this means, it's a natural orifice transinoluminal surgery, but it's hybrid, where there's a transabdominal approach and a transanal approach. And certainly, in this institution, we do it both at the same time, with two teams working at the same time. So you put in your gel port, the transanally you can see your tumor. So essentially, what that means is you can be very precise on where you're going to make your rectotomy. So essentially 1 centimeter below the tumor, you put in a purse string suture and close off your rectum. And when it's tied, you make your rectotomy 5 millimeters below this. And you do a full circumferential rectotomy, and you get into your TME plane, and you do this from below. And the reason why this was brought about and why it's used is that your view in your lower and mid pelvis is very challenging to see the lateral pelvic sidewall lymph nodes as well as the prostate. So you can see how it's easier to preserve the nerves of the lateral nerves of Walsh, as you can see in this picture. So you can essentially continue that plane posteriorly along your total mesorectal as far as you want, and then anteriorly at least until you get to the peritoneal reflection anteriorly. And this sessile approach that we do, you can meet the transabdominal operator from below, and you can use combined retraction from above and below to perform your TME. Then to remove the specimen, if it fits out the anus, and it doesn't always do, you put in your Lexus retractor, move your specimen, you divide your colon where it's good length, and you do your anastomosis transanally. You put the anvil in the proximal colonic stump, and you put a purse string around the cut rectum, and you put your gun through this and form your anastomosis. So the advantages of this is it's a natural orifice extraction site, so less wounds for the patient, and it's easier to visualize the TME distally. It's a relatively new procedure, and certainly it's ongoing continuous audit at the moment. So robotic surgery is gaining ferocious pace at the moment, and as most people know, you have a robotic platform, you have a robotic, which is your console, your robotic device, which inserts its port, and you usually have one assistant holding a laparoscopic bowel grasper. So the advantages of this is, again, it's minimally invasive, you have better visualization, so it's suggesting you can improve urinary and sexually function. Certainly it's a shorter learning curve than the transanal TME, with less blood loss and a lower conversion rate. So essentially, the evolution of surgery is happening quickly, and we're not far away to going back to natural orifice and illuminant surgery, and certainly single port robotics. Da Vinci, there's lots of robotics platforms at the moment, but Da Vinci, to my knowledge, is the only one that has just released a single port robotics, and it's not far away before we're doing a lot of our going back to the notes with a better optimization. In fact, it's the exact same thing as what we're doing already with single port surgery. And one of the major limitations, and I wanted to mention this, is when you're doing minimally invasive surgery, whether it's an intracorporeal anastomosis or advanced robotic surgery, one of the major limitations is always to check the vascular blood supply was hard to do without an extraction site, checking for pulsatile blood flow. So fluorescence is a major advance. While it's been around for quite a long time, it's really come into its own, and we're injecting indocyanine green, and everything that lights up green is well vascularized. So I think we're not far away from doing rectal cancers through a natural orifice technique, a total mesorectal excision. It has been done in cadaveric models, and I know there's some case studies of people doing them at the moment, but it's not quite there. I'm not going to mention artificial intelligence at the moment, but certainly that's coming on. It's already online, but probably interpreted as more complicated than it actually is. So watch this space, and I suppose my advice to everyone is try to keep up with the pace of this. It's very challenging, and so to do transanal surgery and robotic surgery seems to be the direction colorectal cancer is going at the moment, including advanced colonoscopic techniques. Many thanks for your time.
Thank you very much, Peter. And can I just ask anyone who wants to put questions, will you use the chat function? And I'll be very happy to put those to Peter. Peter, I mean, I think the last slide was really one of the most important ones. It's not just something new, it's something better. And that really comes down to the difficulty here, because all of these techniques, it's difficult to be a jack of all trades. And the question is, can you be a robotic surgeon, a TME surgeon, an open surgeon, and a note surgeon, and have all of these skills in the way that people used to call themselves oncological surgeons because they understood oncology? What do you think?
Yeah, I mean, I think it's important to keep up to date, and as a young surgeon, young consultant surgeon like myself, I think we're not far away from amalgamating transanal TME and robotics. So to have both skill set, I think, is a very important to have longevity in a career of rectal cancer management. So I think I think for, as you know, colorectal is now. I mean, you mentioned certainly that it wasn't essentially a subspecialty for many people many years ago. Now there's multiple layers of subspecialty within colorectal surgery. But I think for rectal cancer, I personally think that you have to be able to do robotics, do it open, do it laparoscopic and transanal TME. And I also think where the same person is the right person to do colonic ESD. I think to be able to look at it from a three-dimensional approach is hugely advantageous, and certainly a rectal cancer surgeon should be advanced, should be skilled in all those things.
What I'm obliquely getting at is that within a group of 3 to 5 colorectal surgeons, is there a case for joint decision making and joint operating where one is more skilled at one technique over the other?
100%. In fact, I go as far as saying all complex rectal cancer should be performed by 2 consultant surgeons. And certainly, if somebody's, let's say in our hospital, almost one person does all the extravator APRs with pelvic mesh reconstruction. And I think that's good. And one person does the transanal TME approach, one person does the transabdominal approach when it's done sessile. I suppose you have to be careful. I mean, for not be able to convert from laparoscopic or robotic to open as an individual would be a disaster. I think you have to be trained in a lot of modalities, but I think to work together with both kind of avoids that scenario of someone being underskilled in a certain area.
Okay, I see a hand up. Is it Malachi Gleason?
No.
No. Then is it Veronica Perdigon?
No.
No. All right. Well, somebody's hand is up. You might, whoever it is, take it down then. But do please use the chat function if you want to ask a question. Well, Ian, what do you think of two consultant surgeons operating on the cases? How is an ST4 going to get trained?
Yeah, I mean, okay, that's obviously, it's difficult, but I suppose watching two consultants who are fellowship trained perform a difficult case, there's a lot that can be learned from it. And ultimately, the only thing that really matters at the end is what's best for the patient. But I think, you know, during my research years, I spent a lot of time assisting in a private hospital, and I think I learned a lot more from watching than I'd say learned in the year prior to that. So there can be a lot to be gained from it. I think it's probably only positive. And it's also going to be great for young consultants coming back to know that if you have dual consultant operating, that you're going to have someone more experienced to help you with those difficult cases, and particularly in your early years as a consultant. So I think you can take positives from it, you know.
Well, I have to say the last point there was a personal bias of mine, that it was, and I had the privilege of working with younger colleagues, some of whom had just returned or were in the first few years of their consultant, and operating together certainly was very enjoyable, but also I think good for the patients. Okay, Ian, you're going to tell us about big data.
Yeah, and so more from a kind of genomic point of view as opposed to population health. I just get a slideshow, and you might just let me know when is that slideshow okay?
We're seeing your slide, but we're not seeing the slideshow.
Okay, one sec. What about now? No?
Perfect, thanks.
Okay. Good evening, everyone, and again, thanks for having me on. So I think most people watching will know all about the current staging systems and treatment paradigms in colorectal cancer. And we basically take a lot of data for each patient. So their pathological staging. We look at other factors on their histology, like vascular invasion, and we look at clinical factors such as whether they presented with an obstruction and what their physiological status is like. And we factor all these things in to make informed decisions for patients. And it's a system that works really well for the vast majority of people. But I think most of us will know there are certain patients who are either overtreated or undertreated, or in some cases potentially just put on the wrong treatment that doesn't do them any benefit. And we're going to gradually move towards a system where we're going to have a lot more data on each patient, and that's going to help us make our decisions. With regard to molecular testing in colorectal cancer, again, most people are familiar when you look at your histology reports. They'll see either immunohistochemistry or PCR tests for mismatch repair deficiency and MSI. And that's helping us to identify patients who are at risk of Lynch syndrome, who need further testing done. It's useful for prognostication, theragnostication, and probably in the future, it's going to be useful for deciding on which patients should receive immunotherapy. And people are also probably used to seeing reports on KRAS, NRAS, and BRAF. And that helps us to guide patients, particularly in the metastatic setting, as to which patients should receive things like cetuximab and panitumumab, and which patients won't get a benefit from it. But there's probably more to come. It's pretty minimal testing overall when you look at it, and we're going to have a lot more data in a few years. And people are going to hear terms such as multi-omics and integromics in the future. Multi-omics is basically a combination of genomic data looking at DNA, transcriptomics looking at RNA, and proteomics looking at protein expression. And that's combined with microbiome data and epigenomic data, so looking at how the genome can be silenced by abnormal methylation. And integromics is just an integration of all these modalities into one to try and come up with something meaningful for the patient. So we just take a very brief history of the sequencing timeline. If you go back not so far to 1953, where Watson and Crick discovered the double helical structure of DNA. And then in 1977, Fred Sanger came up with a sequencing method that could be used widespread. And if you ever think that your research is any good, you just have to look at what these guys did in their doctorate thesis, and they'll really put you to shame, because they did fantastic work. And not long after the Sanger method of sequencing came out, we began to identify oncogenes such as the RAS oncogene and BRCA1 and BRCA2. And in 1990, work commenced on the Human Genome Project, which was aimed at sequencing the entire human genome. It took 13 years, and the entire human genome was published then in 2003, after $3 billion were spent on it. And basically, since 2004, there has just been an absolute explosion in next generation sequencing and data generation. And it's been really quite impressive. And you can see that on the graph on the left here, there's a critical point around 2007, 2008, where the number of genomes getting sequenced rapidly increased. And the cost of sequencing then rapidly decreased in line with that. And you can now sequence an entire genome for as little as $99. It's probably not very good sequencing. But in the cancer setting, if you can sequence your tumor genome and your normal genome, the cost at the minute is about $1,000, which is a long way off where we were with the first human genome at $3 billion. So it's much more accessible now. And the reason that it's become much more accessible is that there's been major players in the sequencing industry. So Illumina and Beijing Genomics Institute have come up with really fantastic sequencing technologies. And it's a huge market with a lot of money to be made. So these companies and other companies are constantly competing against each other, constantly bickering over patents and who had the technology first. And it's really very impressive, particularly Illumina's sequencing by synthesis technology, where the data that comes out of it, the DNA sequence that is generated, you only need a fraction of what you put in is actually what comes out. It's basically your DNA is synthesized over and over again, and it's the whole thing is scaled up and you get fantastic data. So the technology has improved a lot. And it begs the question as to where is all this data going, or where does it go? And I'm not a big tech person by any means, and I don't know much about gigabytes or petabytes or exabytes. But needless to say that each of these sequencing tests generates a lot of data for patients. And to give people some sort of tangible understanding, we sequenced 10 patients from Beaumont. And from Beijing, we received a 4 terabyte tower with the data on those 10 patients. And it raises questions as to where all this data is going to be stored in the future. And they're talking about having genomics archives or potentially cloud storage models. And each of those have pros and cons. And then what we then have to ask ourselves is whether all this data that we generate is actually going to be useful. And the answer is that large chunks of it are going to be not useful clinically and potentially not even useful in the academic setting. When we sequence a genome, we get data from all the exons, which is the protein coding regions of the genome, but also a lot of intronic data, which people call junk DNA. And there's not much that can be taken from it, or certainly not at the minute. So it becomes a little bit like trying to find the needle in the haystack. And the big part of what's going to happen in the future is basically cutting the fat and getting down to the meat and trying to identify which of this multi-omic data is actually going to be useful for making decisions in the clinical setting. So that's just a brief overview of multi-omics, but I think what people are probably more interested in for this talk is where does it fit in the setting of colorectal cancer? Where does it fit in with oncology, academics, and in the clinical setting? And I think most importantly is really the patient when they're sitting in front of us. How can we use this data to help them? So firstly, we talk a little bit about just disease mechanisms and etiology. If you sequence a lot of tumors, you can identify the reasons why these tumors occur. And anyone who's thinking about cancer should always think about cancer basically as a disease of the genome. And if you can identify the problems at a genomic level, you can start to identify what makes tumors tick and potentially identify some targets to attack the tumors with. And I think probably people have heard a lot about mucinous tumors most over the last few years and are maybe a bit fed up with it. But we've used mucinous tumors as a model to try and understand the histological subtype. And it's worked out really well because we have identified a pattern of genetic mutations across this histological subtype that have helped us understand why these tumors are the way they are, why they look the way they are, and why they're more aggressive than the non-mucinous tumors. With regard to identifying novel therapeutic targets and drug discovery, again, if you can identify troublesome genes that are mutated, they can clearly be targets. But one of the other things that we began to understand when sequencing a lot of these tumors was that the cancer cells were much smarter than their normal cells, and they tended to overexpress and underexpress normal proteins to their own advantage. And one example we found was that many of the colorectal cancer cells were overexpressing copper transporters, which were basically exporting oxaliplatin out of the cell, and they were reducing the efficacy. So with that in mind, as well as providing people with chemotherapy or targeted therapy, we may be able to provide people with medications which may alter the expression of normal proteins to our advantage to increase the efficacy of the medications we're giving people. But I think, again, really the most important thing is precision medicine. And we're interested in what we can do in the clinic, how we can kind of
okay, thank you very much.
How we can use all this data to our advantage in the clinical setting. And one such way that people probably have heard of is the idea of consensus molecular subtypes of colorectal cancer. And MD Anderson have played a pivotal role in identifying consensus molecular subtypes. And what they've done is they've looked at gene expression data from over 6,000 patients, and they've looked at up to 6,000 genes in each patient. And they've identified 4 groups, as well as a sort of transitional or mixed group. And the beauty of this is that we understand within each group how they're going to behave biologically, and we're going to begin to understand how they behave to different therapeutics. So this will be a way that we can identify patients in the clinic that may respond to drugs like 5-FU versus others who should go straight onto immunotherapy. We can use precision medicine to help us make decisions as to who does and who doesn't need chemotherapy, so we can stratify risk. And again, a lot of the people working in breast surgery will be familiar with Oncotype DX. There is, in fact, one available for colon cancer. It uses 7 cancer genes and 5 reference genes. And we're basically, with this test, the manufacturers claim that you can identify people with stage 2 disease who will get a larger benefit from chemotherapy based on a risk score. And also we can identify people with a low risk of recurrence with stage 3 disease who may not necessarily need to have oxaliplatin added to their 5-FU. So you're basically looking at trying to reduce the burden of chemotherapy given to patients, which is a positive thing as well, and you're not over-treating anybody. Another useful thing is the use of mutational signatures, and this is looking at a pattern of mutations and forming signatures for each tumor. And these signatures are useful in predicting etiology and also response to treatment. And we'll just use 2 examples that people can look at case H. You can see there's 2 areas, one in purple and one in pink, and these have the signatures 20 and 44, which are mismatch repair deficiency signatures. And this was the only mismatch repair deficient tumor in our cohort. So that helps you understand the etiology or the pathway that this tumor arose on. And in case G, 4th from the bottom, the color, it's a slightly brown color. It's signature 3. This is known as a homologous recombination deficiency signature. It's a signature that's associated with mutations in ATM and BRCA. But most importantly, it's a signature that's associated with a really good response to PARP inhibitors. And they're not traditionally used in a setting of colorectal cancer. So these kind of signatures can help us identify new pathways with which we can treat patients. And then finally, this is probably really where the money is at, and this is what's currently available. A contact I know in molecular health sent me, this is a demo report from whole exome sequencing from a patient with KRAS mutant rectal cancer. And what they'll do is they'll generate a report for the clinician, and it's a bit like reading a radiology report. They'll tell you what drugs are likely to work based on the pattern of mutations and on the level of evidence. But equally, they'll tell you which drugs aren't going to work and which drugs may cause toxicity. So you can see here on the right, this patient is a KRAS mutated cancer, and they're telling you that basically the 2 EGFR inhibitors in the market, panitumumab and cetuximab, aren't going to work here. So you can avoid giving your patient that treatment and focus on some of the other treatments that are more likely to work. So, with all this data comes specific challenges, and I think all of us will are familiar with the scene on the left, which is a typical MDT, a bunch of clinicians sitting around the table from different specialties, looking at radiology and pathology data, talking about the patient and making informed decisions on a relatively small amount of data. And the big problem we're going to have now is how do we take this vast amount of data that we have and bring it to MDTs and discuss it in a reasonably fast fashion, and that will allow us to make the best treatment recommendation for the patient. And that's going to involve basically creating a bridge between the clinicians and the bioinformaticians that we can extract what's clinically relevant for our patients. We're also going to need to train a whole lot of people up in genomic oncology, and you can see the NHS are kind of far ahead with this. They're already looking at clinical bioinformatics and how they can improve things and get the numbers of people out there needed to match the demand in the future. And as surgeons, we won't be able to just put our head in the sand with this. We're probably going to be asked to take extra biopsies at the time of our initial diagnosis to be sent for rapid sequencing. And much of this data is going to become available to us at the first MDT the patients discuss that. and it may influence how patients are treated, whether they undergo upfront chemoradiotherapy or whether they're brought straight to surgery. So we're going to need to get involved in those discussions. There's this issue as well of a bioinformatics bottleneck. Again, it probably won't affect us too much, but there's a huge amount of data out there, and we're going to need a lot more bioinformaticians trained to analyze that data and generate these meaningful reports for us. So there's going to be room there for both clinical bioinformaticians and also people from science backgrounds. And then I think you can't really mention kind of genomic data or transcriptomic data without talking about data protection and protecting our patients in the future. It's a major issue. This data obviously can't get into the hands of the wrong people. And you know, with everything that's gone on in the HSE recently, I think we're probably more aware of the risk of cyber attacks and what can happen. But equally to be balanced against that is that the data should probably be made publicly available and be anonymized. And myself, and I'm sure Emer, who may or may not be listening, Emer O'Connell, we've got huge benefit out of publicly available data with our research by using the Cancer Genome Atlas data. So there's a balance to be made between how we protect the patient's data, but how we also make it useful to researchers going forward. And for anyone who thinks that protecting your genomic data may not be a big issue, this is just an example. There's an Israeli company who can take your data off a USB or your whole genome sequencing data. They can synthesize your DNA, and they claim they can put you at any crime scene in the world by putting your DNA there. So it's probably a bit far-fetched, but clearly, you know, we don't want kind of similar scenarios like this arising, and our data is going to have to be protected in a very kind of focused manner going forward. So thanks very much. I'll be happy to take any questions that anyone has about that.
Well, goodness, Ian, that was a lot of food for thought, and thank you very much. Lots of things that occurred to me. I mean, I'm sufficiently long in the tooth that I remember when Des Carney was appointed, I think, as one of the first clinical oncologists, and Dr. Fennelly Senior was one of the first clinical oncologists in the country, until relatively recently, it was almost impossible to get genetic counselling outside of referral to Crumlin. So we're way behind in terms of the resources to deal with this. And the question I have for you is, this is all very well, but how are we going to catch up even with where people are? Never mind trying.
You know, hopefully won't be as big an issue as we think, but certainly I think we're going to have to train a lot of oncologists, and probably there's going to be surgeons who are going to take an interest in genomics as well, to deal with the vast amount of people coming through, and how we guide them through what's going to be a very tricky treatment pathways, because people aren't going to go through your standard pathways in the future. They're going to go through very personalized pathways, and initially it's going to be very difficult to assure people that the pathway they're going through is going to be a good fit for them, compared to maybe putting them on a standard pathway of 5-FU and oxaliplatin. And I think how it's going to be dealt with in the first instance, I think we're probably going to deal with a lot of people with stage 4 cancers who are running out of treatment options. And I think if we start sequencing those people and finding alternative treatment regimens for them, if we start to see positive results, that can be slowly brought backwards to those with stage 3 and high-risk stage 2 disease, and we'll be able to give people some guarantees about their treatment. But we're going to have to ramp up the numbers of people who are involved in this kind of in this kind of personalized medicine, and that's the only way, because everyone should have equal access to it going forward. It shouldn't just be people in certain centres. All patients should have an option for personalized treatment.
But the great difficulty with this is there's always another monoclonal antibody or small molecule that might work, and that the cost of this is becoming exponential.
Mm-hmm. Yeah, like and then there's no denying that it's an acceptable point. And I think what we have to do with those kind of things is you've got to leave that up to our National Centre for Pharmacoeconomics, and they're going to have to make individual decisions based on treatments and quality of life and survival and cost effectiveness, and that will be taken out of it should be taken out of the hands of everyone else, and it'll have to be done on a case-by-case basis as to which drugs we approve. But you're right, we simply just can't approve every monoclonal antibody, because the money has to go to other things. You know, hip fracture pathways and care of the elderly and different things. So it's a finite pool, and again, we just have to assess each drug on a cost by cost basis and look at what value it's offering, and clearly define, what we as a society agree what's valuable and what should be paid for.
Well, that's a difficult, almost a theological argument. I don't know. Paul Balfe wonders, is multi-omic profiling currently available to any Irish patients outside of a research setting?
It is, yeah. So Molecular Health in Heidelberg will offer it, whole exome sequencing for about €1,000. And all the patient has to do is the patient's oncologist needs to do is fill out a form, and Molecular Health take it from there. They request the FFP blocks from the hospital, and within about 3 or 4 weeks, the oncologist will have a whole exome sequencing report in their hand. So it is available, but you'll be sending your samples off either to somewhere like Heidelberg or across to Boston to One Health, but not in Ireland. Not in Ireland, as far as I know. I know GMI is getting set up, so I presume we will have a local kind of facility to do it in the near future, but it is available pretty easily through some international centres.
But of course, what you need is the interpretation of all of that data rather than just getting the data back, and that almost like culture and sensitivity your report you showed was probably what we need.
Yeah, it has to be simplified, doesn't it? I mean, someone has to be able to look at it and read it like a radiology report. Because if it's any longer, it becomes meaningless. And if you present someone with 500 options for what medications work, I mean, where do you even start? It's just like a shot in the dark. And so it has to be very concise and focused. And there are oncologists that are interested in this. I know Professor McDermott in Vincent's uses it for some patients. So as people get more experience, it will become more standard.
And my last question for you, Ian, when 30 years from now you're looking at retiring from your position, will you still be operating on colorectal cancer?
I think we'll be much more selective. I think there's going to be groups of patients that we're going to be able to pick out that are going to be highly responsive to chemoradiotherapy and targeted therapies, and they'll have prolonged responses. And I think multi-omic data is going to be allow us to pick out the ones that need to be operated on versus those who will be treated and followed clinically. But I think we will probably still be operating on patients with colorectal cancer in 30 years. Certainly groups of them. We know some of those consensus molecular subgroups, the mesenchymal types, are going to respond very poorly to treatments. So there will be some, definitely, I think.
Well, you can console yourself as a colorectal surgeon. They'll still have hemorrhoids, so you'll have something to do.
Yeah. Good. Thanks very much.
Thank you. And we're now inviting Caroline Fogarty, who's the clinical nurse specialist in colorectal cancer at Beaumont, to tell us about the patient, and really the most important component of the whole thing is the patient pathway. And so, Caroline, we're looking forward to hearing from you.
Thank you. Thank you very much, Professor, and thank you for the invitation to speak here this evening. I am a colorectal clinical nurse specialist in Beaumont Hospital, and I work with the colorectal team there with Professor Deborah McNamara, Professor John Burke, and Miss Niamh Macaulay, and I am one of 3 colorectal nurse specialists in the colorectal department there. So if I could just have the next slide, Pauline. So just a brief mention about the role of the colorectal clinical nurse specialist within the colorectal service. My job is to meet patients at diagnosis of a colorectal cancer and to explain and arrange the cancer staging process. I am their main point of contact with the colorectal service from diagnosis through their treatment and beyond. We ensure the patient has a good understanding of their treatment plan and explain and answer any questions about their surgery or their treatment. We provide post-operative and discharge patient education, and are a key communicator and advocate for the patient within the colorectal service, and as a liaison to our colleagues in medical oncology, radiation oncology, urology, gynecology, whatever other services are needed for the patient. And another main part of our role is to coordinate colorectal cancer surveillance and survivorship for 5 years post-diagnosis. And the next slide, please. Some of the benefits of nurse specialist surveillance are, we, as I said, are the main point of contact for patients with within the colorectal service, and that provides a continuity of care for them throughout their treatment and throughout their 5-year surveillance program afterwards. So over the course of this time, they get to know us. To get to know us quite well in the midst of teams that are changing over the course of this time. We offer specialist knowledge and advice on colorectal cancer and its treatment and the management of side effects of treatment in a timely way, and helps to with the early identification of problems and a more speedy resolution for any potential problems that the patient may have. We provide emotional support and education for patients and their families, and we provide a coordinated surveillance program to promote survivorship. So the next slide, please. So as everybody knows, the colorectal cancer 5-year surveillance guidelines, when patients have finished have been through their surgical pathway and their treatment, they have a CT tap every 6 months for 2 years, and then yearly to year 5. Concurrent to this, they have a CEA blood test every 6 months for 2 years, and then yearly to year 5, and a colonoscopy at year 1, year 3, and year 5. And the next slide, please. So in order to help us better coordinate our surgery and surveillance service, we in Beaumont developed a colorectal surveillance passport, and it has been in use within our service since 2014. And the purpose of the passport is to guide the patient through their surgery and through their subsequent 5-year cancer surveillance program. It is given to patients prior to discharge from hospital following their surgery, and it contains discharge information, contact numbers, when to contact us, what the next steps are regarding outpatients to come back for review or results, and the main points of contact for our stoma care service. And subsequent to that, then, when they've finished any potential adjuvant treatment, it outlines their colorectal cancer surveillance schedule. It's a live document, I suppose, in that it's updated at every clinic visit by the colorectal nurse specialist with results of investigations and any next steps or anything that we need to arrange for the patient. And it's used in much the same way as perhaps a patient on warfarin might bring their warfarin book to each clinic to have it updated and to have their treatment plan updated. So the next slide, please. So the concept of survivorship, of cancer survivorship, focuses on physical, emotional, and financial issues that are unique to cancer survivors. It's about managing the long-term side effects of cancer and its treatment and the promotion of a healthy lifestyle. And these are also issues that we address on our surveillance program as well. Next slide, please. The phases of survivorship. Survivorship starts now at diagnosis through to the end of initial treatment with surgery or with chemoradiotherapy and adjuvant chemotherapy. The extended phase of survivorship is when initial treatment is finished with the surgery and treatment regimes, and the effects of these interventions are the focus for the patient. And then a more long-term view is a permanent survivorship, when patients have passed the full, emergency of their cancer and its treatment, and the long-term side effects of that on them and their lifestyle and their families. Can you hear me?
Caroline, yes, I think somebody just put on their mic and there was some background noise. Yes, we can. You guys
can hear me. Great. May I have the next slide, please, Pauline? Thank you. So good cancer survivorship encompasses clearly information and health education for the patient, encouragement of self-management, monitoring and intervention for psychological and social effects of cancer, as people are living longer with the consequences of their treatment, familial genetic risk assessment, guidance on work and financial issues, and guidance on cancer prevention and healthy lifestyle advice. Can I have the next slide, please? So the NCCP have done a lot of work around survivorship in Ireland, and Louise Mullen and Terry Hannon in particular carried out a comprehensive review of cancer survivorship in Ireland, and developed a survivorship needs assessment that was published in 2019, and there are a number of recommendations from that. And they identify that one key contact at each phase of the cancer journey is critical to patient engagement in survivorship programs. They identify that patient empowerment through the survivorship process should be encouraged for self-management, and survivorship services should include patient-specific information in cancer-specific follow-up clinics with rapid access to symptom control, management and resolution. And crucially identify that a patient treatment summary and care plan should be given to each patient as an integral component of a survivorship program to help encourage self-management during this process. So this presented us with an opportunity to further develop our colorectal passport, looking at surgery and surveillance guidelines to a more comprehensive document encompassing all aspects of colorectal cancer and its treatment. So may I have the next slide, Pauline, please? Thank you. So that led to the development of the patient passport, the treatment summary and care plan for patients with colorectal cancer. And we were approached by the NCCP to develop this document to further include information on chemotherapy and radiotherapy from diagnosis to colorectal cancer treatment, to diagnosis and treatment along the colorectal cancer treatment pathway. It enabled our document, which looked at surgery and surveillance, to grow to become a care plan that looks at all aspects, as I said, of the patient journey through the cancer pathway. And it's now given to patients at diagnosis, and they keep it and have it updated at each visit, both with us in the colorectal clinics and at the medical oncology and radiation oncology clinics also. So you can imagine that this collaboration with the NCCP was a big project, and we did a lot of work in Bowman to get all the information, all the relevant information together from our colleagues in medical and radiation oncology. And then the NCCP, facilitated a process with us of collating all that information and getting advice and revision and review from nurse specialist colleagues in other pilot sites to develop a comprehensive document. So the next slide, please, Pauline. So the purpose of this passport is still to act as a patient's guide and reference to each cancer step from diagnosis through treatment and beyond. It begins clearly at diagnosis and is updated at each clinic visit by the colorectal nurse specialist that the patient sees, who is their main point of contact at each step through their cancer pathway. At the end of their cancer treatment, it outlines the patient's schedule on the colorectal 5-year surveillance pathway. It is pocket-sized, and patients are advised to bring it to each appointment so it can be updated. It can be a very difficult and overwhelming time for patients, and to have a written guide with results and next steps to hand is really important. Importantly, it does not replace normal hospital correspondence to GPs and other services. Rather, it is a patient guide to their treatment and surveillance. And it includes information on general healthy lifestyle and various cancer support services that are available. And to have this information, we found in our practice in Beaumont, really empowers patients to take responsibility for their own surveillance and survivorship. And for example, if they have a schedule and they're expecting an appointment for CT scans, for example, and they for some reason haven't got one, they will ring us and contact us and say, look, I have my schedule here and I don't have an appointment yet. Can you follow up for me? And we're obviously more than happy to do that, and delighted to hear that that I'm glad to hear that they have that they're able to contact us so we can follow up on their behalf rather than being lost to follow up. The next slide, please. So this new incarnation of the colorectal passport, the colorectal cancer treatment summary and care plan, was introduced to pilot sites in October of last year. And the pilot sites currently are the Mater and St. James's Hospital in Dublin, Our Lady of Lourdes in Drogheda, Limerick University Hospital and the Mercy Hospital in Cork. And we have got patient and staff feedback at 6 months, which is currently being collated. And we will send patient and staff review again in 12 months. And then we will work on amending the document as appropriate before a national rollout of this treatment summary and care plan. So in Beaumont, I suppose we're lucky enough to have been working with this document for, it's been ingrained in our practice for a number of years now. So we're actually looking at sort of further developing it into an app-based platform that will contain patient-specific information that's updated at clinic visits. And thus the patient has their own personal record of their diagnosis, their type of surgery, their treatment plan and their surveillance going forward. So work is ongoing at the moment to get this established. So if we could just have the next slide, please. So this is just a picture of our mock-up of what the plan is that it will look like. So each patient will have a code or a link to their app. They will download the app, they will put in their code or their link, and they will get patient specific information under each of these headings. So for example, Caroline Fogarty is to have a right hemicolectomy. When I go into the colorectal surgery tab, I will get information specifically on right hemicolectomy, and then subsequently what to do on the day of my surgery, any preoperative instructions, and etc., down through going home and discharge advice and treatment and surveillance afterwards. So that is the long-term plan to develop this within our service. And the next slide, I think, is the references, and that's it. So thank you very much.
Caroline, I have to say that was fantastic, and nobody could underestimate the amount of effort and work and everything else that has gone into developing this. So well done, and it's wonderful to see it being rolled out to other sites. And I had written down here, what about an electronic version? And there you're ahead of me. The problem I foresee, though, is the enormous workload in the background, keeping all of this up to date. I don't know if you want to respond to that, but I mean, have you created something that is an all-consuming, hours-consuming process?
Sure. Well, I suppose it was important to us when we've been using this document that this is a patient document, and it doesn't replace any correspondence from the hospital, within the hospital, or to outside the hospital to GPs, for example. So it's a reference document for the patient, and the idea was to keep it as simple as possible, to keep it updated, but to keep it as simple as possible. So no doubt, you know, when you're introducing any sort of change, there's a bit of upheaval. But actually, we've been using the colorectal passport now for 7 years, and it's just ingrained in our practice now to update the relevant points. You know, I suppose specifically results of CT scans, results of CEA, the results of colonoscopy when these things are next due, and then any other specific issues or concerns or next steps that the patient has. But it doesn't replace the patient's notes or record. It's just a guide to them as to what's going on behind the scenes in the hospital for them, so that I suppose as we get further down the line of the treatment pathway and they're hopefully forgetting about coming to hospital, that they don't forget for too long and they go, oh, I am due a scan this year, and she was looking into, you know, a medical card or liaising with medical social work for me, and that they have that as a guide for them going forward.
And how has COVID interrupted all of this?
Sure. So I suppose we're with the advent, we're doing more and more appointments virtually, particularly for our surveillance patients, obviously. So for us, we can, because we're so used to using the passport, we say, well, we're on the phone, do you have your passport? Can you update it? Will you write in it now? And of course, you're hoping that your patient, when they put down the phone, remember to do that. But I can imagine when it's not as ingrained in your practice that it's a little more difficult to remind yourself to do that, and that is an important piece, because if it's not a live document and currently and continuously updated, then it's not necessarily something the patients will use and they'll forget to bring with them. So you do have to be very conscious to remind them to bring it to appointments, or to update it themselves with what you've discussed, or with the letter that you sent them of what you've discussed, when you're not in a position to do it yourself.
And the last issue I want to raise with you is emotional support. I mean, I think this is one of the crucial things that a clinical nurse specialist gives during the acute phase. But what, if any, training do you get? I mean, is this learnt on the hoof? Or do you envisage that there is a module that would be helpful in doing that, and extending that? Should other members of the team be doing it as well?
Well, as you rightly say, it's such when the initial diagnosis and the emergency, I suppose, of cancer presents to somebody, people clearly require a lot of emotional support, because they're not always in the best position. Once they hear the word cancer, you don't hear anything else, and they do need a lot of emotional support. It's not something that you are always formally trained on, and it is something that you learn through experience, through your general nursing experience, and through our work in the colorectal service. I find I personally learned on the job, and I learned from my colleagues, and I learned through my own nursing experience, and the importance of your communication skills, and actually even for patients to know that you're their main point of contact, that if they call you and leave a message, that you will phone them back, that behind the scenes people are working for them to keep things moving for them, and to keep them moving along their pathway. That is really important, and that is a huge part of our role, and a huge comfort, I would like to think, to patients, is they tell us that it is, that you'll always phone us back, and we have an open door policy, I suppose, and we never really discharge patients, even though they are discharged at the end of their surveillance program. But very often they will come back to us. But also we do rely very heavily on community supports with the Irish Cancer Society, with ARC, with the other various cancer support groups that are available, and that in the community we try to liaise with them as much as we can, because there is so much pressure on all the acute hospital services at the moment.
Well, Caroline, thank you for those insights and for the work that you're doing on behalf of so many patients. And I have no doubt that all listening this evening greatly appreciated your input. Which brings me just to the end of this session. We've had several messages in on chat complimenting our speakers, and I want to join in those compliments. We have had 54 Wednesday evening webinars now since Kenneth Mealy started them as the COVID pandemic broke, and they really started as information. It was a very, very appropriate thing to do to inform the surgical community and keep them up to date with developments. And it has morphed into a series of clinical professional development type webinars covering the clinical programs, international surgery, various specialties, regional issues, medical legal issues, and training sessions. And when these are all been recorded and they're available on the RCSI surgery website, if anybody is inclined to go back, because there is an enormous wealth of information there that is, I'm sure, a resource going forward. It is a bit resource intensive, and there is discussion ongoing within the college that we should probably move to a fortnightly or even monthly format. I'm minded to recommend a fortnightly format, but it would be very helpful to me, and I'm bringing this to council next week for a decision, to get some feedback as to what those of you who do tune in, and you're over 100 every week, sometimes close to 200, and on one occasion over 300. What you think of the format. Would you prefer a weekly one, a fortnightly one, or less frequent? And suggestions for topics that we haven't already covered would be very helpful. So any feedback would be of value. I think Pauline may correct me, but I think we're going to send out a poll to people who have tuned in, asking for your suggestions. So Professor Laura Vianney, the Vice President, and I are having a meeting to try and plan from September on, after Council gives us guidance, but we will be primarily guided by you who tune in on Wednesday evenings and who have enjoyed it. I see Liam Joyce is coming in. Please keep it a weekly format. That's my bias too, Liam, but it does require resource in the college, and we'll have to look at that. But that's very helpful. So thank you again, Caroline, Peter, and Ian. One of the best webinars we've had, covering everything from surgical oncology to surgical technique to really the most important issues about patient survival. So thank you all. Good evening. I hope you have a good summer, and we will see you back in September in a new format. Thank you and good evening.